Ready?
Another minute or so.
Okay.
I'll let you know when to introduce. It's not 7:30 yet, so we'll wait till 7:30. So. It's 7:30 and good morning. Welcome to Pediatric Grand Rounds. This will be the final presentation by our graduating fellows today, and it will be Dr. Mahwish Khan from the Pediatric Endocrinology Fellowship Program, Dr. Jane Lynch, who is the Chief of Pediatric Endocrinology and Program Director for Pediatric Endocrinology Fellowship, will be introducing today's Grand Round speaker. Dr. Dr. Lynch, go ahead.
Thank you. So Dr. Mahwish Khan is one of our two third-year pediatric endocrine fellows here at UT Health, who's graduating next month. She is originally from Atlanta, Georgia, where she finished her undergraduate degree in biomedical engineering at Georgia Tech, and then moved to Fort Worth, Texas for medical school at North Texas Health Science Center, osteopathic medicine. Dr. Khan completed her residency here in San Antonio with Baylor College of Medicine, and now has spent 3 years with us doing pediatric endocrinology. Her clinical interests include pediatric obesity, steroid-induced hyperglycemia and diabetes, and social determinants of health. One of her projects is what she's presenting today, which is a very interesting study looking at technology with the use of steroids and high-risk kids for hyperglycemia to see if they will tolerate wearing continuous sensors. She spends time with her husband, who was also Dr. Khan prior to them meeting, and they have 3 children, a very rambunctious couple of cats, where she spends time at home with cooking and baking and other hobbies. So I'm thrilled to hear her talk this morning.
Thank you, Dr. Lynch, for that really nice introduction, and thank you all for joining in for my talk this morning. Today, we're going to be talking about a topic that I have learned and researched on a lot during my fellowship, and that topic looks into understanding malglycemia in youth with acute lymphoblastic leukemia. And so I have no disclosures. And let's get into it. So I want to just talk and begin with glycemic control and why it is so important to be looking at blood glucoses and why it's so important to intervene. So we know that recurrent hyperglycemia is associated with micro and macrovascular complications. These are things like retinopathy, nephropathy, atherosclerosis. And in both the acute and chronic cases, recurrent hyperglycemia is associated with an increased risk for infections and poor wound healing. Recurrent hypoglycemia presents acutely with seizures and altered mental status. But in pediatrics specifically, hypoglycemia is especially important to identify because of the potential long-term neurodevelopmental impairments that can be seen in children. Type 1 diabetic patients who have recurrent hypoglycemia also experience a 3-fold increase in the mortality of their disease. So these are things that we should be watching for and treating as appropriate in our populations. When we think about specifically patients with acute lymphoblastic leukemia, this is a really interesting population to consider. So when we talk about malglycemia, I define this as the occurrence of hyperglycemia, hypoglycemia, and glycemic variability. And when we look at the ALL population specifically, up to a third of children who are in treatment for ALL will end up developing malglycemia in some form or another. There's multiple different risk factors for malglycemia. If you're above the age of 10, if you're female, or if you have trisomy 21, you have increased risk for malglycemia. CNS involvement confers increased risk for malglycemia. in addition to a family history of diabetes and an elevated BMI. And these last 2 points are specifically interesting because when we look at our San Antonio population, for example, we have very high rates of diabetes here. We have a high amount of obesity, which means that we probably in our population here locally have a high genetic risk for insulin resistance, and that confers increased risk for malglycemia in general. When we look specifically at hyperglycemia, as I mentioned before, hyperglycemia in ALL is associated with the increased risk for bacterial and fungal infections. And in patients who have significant enough hyperglycemia to require insulin, these patients tend to have a higher need for bone marrow transplant, a higher risk for disease relapse, and lower survival. They tend to stay in the hospital longer, they're more likely to require ICU admission, and they tend to have a higher overall cost of care. And these complications of hyperglycemia are not unique to ALL. They're also described in adult cancer patients and in pediatric hematopoietic stem cell transplant recipients. And when we look at the reasons for why malglycemia occurs in ALL, there's multiple different causes. Of course, there's medication and chemotherapy related causes for malglycemia, which is going to be a bulk of what we're going to be talking about today. But there's also underlying insulin resistance and obesity. So for patients already have an elevated BMI, they're already in the pre-diabetic range, they tend to have a higher risk for higher blood sugars. Stress hyperglycemia, these patients are often critically ill. And in critical illness, you often have an intense counter-regulatory and cytokine response that leads to overall hyperglycemia. These patients can be on TPN with high amounts of dextrose that are being brought in to help with their caloric intake and meet their nutritional needs, and that can exacerbate malglycemia. And then these patients are also at risk for having poor feeding tolerance, which can lead to the opposite side of the spectrum, which is hypoglycemia. So when we think about the unique causes for malglycemia in ALL, one of the big things that we should be thinking about are our chemotherapy agents. And the most commonly implicated agents that have been known to cause hyperglycemia include our glucocorticoids and asparaginase. And the idea behind these two drugs is that they tend to work synergistically to cause higher blood sugar, specifically during the induction phase of chemotherapy, which is the first phase of chemotherapy in ALL treatment. And so is the common time frame for when we see higher blood sugars in this population. When we think about hypoglycemia, the most talked about agent is 6-mercaptopurine, which is an antimetabolite. And so chemotherapy agents do tend to increase the risk for malglycemia in this population. One of the really interesting agents to talk about and consider are glucocorticoids, because while they are used in treatment for ALL and chemotherapy, they're used in a widespread range of other disease processes and inflammatory, rheumatological, dermatological, and oncological processes. And they affect glucose homeostasis at various different levels. One of the ways that glucocorticoids lead to glycemic abnormalities is through the promotion of hepatic gluconeogenesis. And glucocorticoids do this by promoting the transcription of genes that encode enzymes of the gluconeogenic pathway. And I put the pathway up here. This isn't a biochemistry lecture, so we're not going to go into all the specifics of how gluconeogenesis occurs. But it's important to note that glucocorticoids have effects at this level in the liver. This isn't the only place where glucocorticoids exert their effects. They have effects widespread all over the body. In the muscles, glucocorticoids increase fatty acid oxidation. They increase proteolysis, allowing for increased amino acids to provide substrates for gluconeogenesis. And they decrease glucose uptake in the muscle. In the adipose tissue, they increase lipolysis, leading to increased glycerol, which is another substrate for gluconeogenesis. They also decrease glucose uptake in adipose tissue. And in the pancreas, they increase beta cell failure and lead to overall a diabetogenic effect. So glucocorticoids have effects all over the body and in combination lead to insulin resistance. Asparaginase is one of the other really interesting medications that's been implicated in hyperglycemia, and asparaginase functions by depleting asparagine in leukemic cells. When we look at insulin synthesis is dependent on asparagine. So if we're depleting asparagine, we will have less insulin in our system. And without as much insulin, that tends to lead to hyperglycemia. Asparaginase has also been shown to decrease the expression of our insulin receptors, leading to overall insulin resistance. And there's been a lot of literature that has shown increased risk of pancreatitis in patients who are treated with asparaginase. In fact, up to 2 to 18% of patients who are treated with asparaginase will have some form of pancreatitis. Pancreatitis can lead to beta cell dysfunction that is either transient or permanent. And patients treated with this agent can have low insulin and have acute complications such as DKA. And that's something that I've personally seen in patients treated with asparaginase. When we think about insulin resistance, it's important to also look at its role in cancer progression. As I mentioned previously, our patients with hyperglycemia and significant hyperglycemia requiring insulin use tend to have lower survival and increased relapse. And there's different hypotheses for why this can occur. And one of the things that's been looked at in the literature is the idea that insulin resistance leads to an increased demand for insulin and the binding of insulin to insulin-like growth factors on leukemic cells. This binding can drive the proliferation of the leukemic cells and could be a hypothesis for why some of our patients with hyperglycemia tend to have decreased rates of overall survival. When we're looking at the opposite spectrum of blood sugars, when we're looking at hypoglycemia, there's multiple different reasons for why this can occur in this population as well. If we're looking specifically at chemotherapy agents, so anti-metabolite therapy, agents such as 6-mercaptopurine have been known to cause hypoglycemia, specifically during maintenance phase of chemotherapy, which is a later phase of chemotherapy in ALL. Secondary adrenal insufficiency is a really interesting concept that we'll talk about in the next slide, but has also in the literature been suggested as something that can lead to hypoglycemia. And then poor feeding tolerance. So this is a population that is already having difficulties with eating. They may have mucositis. They may have difficulties with their taste. And so they're at high risk for hypoglycemia, especially around the time of fasting. And these patients often have to undergo long periods of time being NPO for their procedures. The highest age risk groups are those who are under the age of 6 and those who already have underlying hepatotoxicity. And again, hypoglycemia is important to identify and important to treat because in pediatrics with growing brains and rapid development, untreated hypoglycemia that's recurrent can lead to neurodevelopmental problems. So let's talk about adrenal insufficiency a little bit more because this is something that hasn't been discussed as much in literature. But the concept of adrenal insufficiency in ALL is interesting because our patients in induction chemotherapy will be treated with 4 weeks of supraphysiologic doses of glucocorticoids. And we know that being treated with steroids for that long of a time frame can often lead to adrenal suppression. And that suppression of the hypothalamic pituitary adrenal axis can last for several months after corticosteroid therapy is discontinued. And what are the symptoms of adrenal suppression or adrenal insufficiency? There are things like fatigue, nausea, hypoglycemia, hypotension. And these aren't symptoms that are unique to adrenal insufficiency. Our patients who are on treatment for chemotherapy can already have these symptoms. So it's something that we hypothesize in the endocrine world might be underdiagnosed in the ALL population, especially because we don't have a protocolized taper off regimen after they're completing their induction chemotherapy. There have been several case reports in the literature and even patients that, I have seen personally who have had hypoglycemia in the setting of adrenal insufficiency after receiving high-dose glucocorticoids for their treatment. So it is something that will be interesting to learn more about as time goes on and something that we believe may be a contributor to hypoglycemia and malglycemia in this population. So how well do we do at diagnosing malglycemia? We've looked at what are the causes of hyperglycemia and hypoglycemia, what are the risk factors. So this is well known. And the answer to that question is that we really don't have any established guidelines or practical approaches for monitoring for these glycemic abnormalities during pediatric ALL treatment. What's currently done is that these patients come in for their weekly lab draws. These lab draws may occur during a fasting state or a non-fasting state, and sometimes it isn't completely known whether they're fasting or non-fasting. And so the parameters for which we identify malglycemia vary depending on the fed state. In addition to this, practices and definitions for hyper and hypoglycemia tend to vary between institutions, and they vary even in the literature. And the parameters at which to start treatment also vary between institutions and providers. So for a population where treatment is very well protocolized, we don't have a protocol or an evidence-based guideline for the surveillance of hyperglycemia and hypoglycemia, and we also don't have an evidence-based protocol for the treatment of malglycemia. So this is something that's definitely needed as time goes on to improve treatment and improve long-term outcomes for these patients. So when should we expect hyperglycemia? Because we know that there are certain agents that lead to different glycemic abnormalities, and we know that these agents are used at certain time points during chemotherapy. So we talked about asparaginase and glucocorticoids working synergistically during chemotherapy to lead to hyperglycemia. And I really like this graph because it helps to really identify when we should start to see a rise in blood sugar secondary to these agents. So this is a graph that looks at a number of patients who received induction chemotherapy and looked at their blood sugars over that time period. And that blue line denotes blood sugars during the daytime, and the red line looks at overnight blood sugars. So already you can see that your higher blood sugars tend to be seen during the daytime. In addition to that, we can see that the timing of asparaginase can be a big factor in when hyperglycemia tends to happen. PEG asparaginase in this subset of patients was given around day 6 or day 7 of treatment, and the highest rise in blood sugars was seen about 3 days later. So the peak glucose is seen in induction chemotherapy during this study was around day 10 of treatment. And that's something that we can look at and expect when we're thinking about creating protocols for surveillance in this population. So steroid-induced hyperglycemia is first seen during the daytime, and it's usually seen around meal times. That's when you have the highest peak in blood sugars. When we're looking at routine glucoses, when we're looking at what's currently done as far as surveilling for malglycemia in this population, we know that fasting glucoses would not be the most appropriate first method for looking at blood sugar abnormalities because they're not usually the first value that's elevated. So prandial glucoses are often the first most appropriate method for identifying malglycemia in this population. So what does literature tell us with glycemic monitoring in ALL? We have a lot of literature that looks at the incidence and prevalence of malglycemia, but the definitions of malglycemia in the literature vary. So we know that our normative glucose values are between 70 to 140. So there are certain papers that have looked at glucoses greater than 140 as an appropriate definition for malglycemia in ALL. There are certain papers that have looked at fasting glucoses of above 100, but we know that fasting glucoses may not be the first value that are affected in this population. The most common definition that I've actually seen reported is any glucose greater than 200 identified at least twice. So that's the most common literature definition of malglycemia that we have. But what should our target glucoses be? And I think this is an important topic to talk about because when we're thinking about surveillance, when are we starting about when should we be starting surveillance? When should we be looking at starting treatment in our ALL patients? And we can look at different things. ADA, or the American Diabetes Association, suggests that patients who have steroid-induced hyperglycemia should have typical targets as diabetic patients. So what are those typical glucose targets? Time and range for our diabetes patients can be between 80 to 180, but should we classify our ALL patients under this diabetes category? And hospitalized patients or those who are at risk for hypoglycemia, those who are critically ill, what has been suggested in the literature is a target glucose of about 140 to 180. We still don't have any true large pediatric studies that can definitively tell us what our typical or appropriate target glucose should be. And those have yet to be established. But this is what we can fall back on when we're looking at appropriate glucose ranges for this population. So when should we treat malglycemia? As I mentioned before, in our critically ill patients, you want to target a blood sugar of 140 to 180. But that would be in patients who are at higher risk for hypoglycemia. So we can hypothesize that an appropriate target glucose in this population could be a glucose that's less than 180 milligrams per deciliter without hypoglycemia. And the treatment of choice for malglycemia is insulin. Now, when we're thinking about treating our patients and looking at how to identify malglycemia in this population, the most common method of identifying hyperglycemia is either through your serum glucose or through multiple finger pokes daily. And this can be distressing in a population that's already receiving interventions for, their ALL. And so multiple finger pokes are painful, they're annoying, there's thoughts that maybe there's an increased risk of infection, maybe increased risk of bleeding with low platelets in this population. So let's talk about some of the other methods, some potentially easier methods of looking at blood sugar patterns in other populations and why these may or may not be an appropriate method of surveillance, specifically in ALL. And the most common biomarker that we're all familiar with is the hemoglobin A1C, or glycated hemoglobin. And what is the hemoglobin A1C? So an A1C is basically what is created when glucose naturally binds to hemoglobin. And that binding is what creates glycated hemoglobin. And so this is a measure of looking at glucose values over a 3-month period, because the lifespan of a red blood cell is approximately 120 days. And so this is a great method for monitoring hyperglycemia and glucose control in the diabetic population. But is it appropriate for our ALL population? And the answer to that is no. It is not an appropriate method to screen for hyperglycemia in pediatric ALL. It might be appropriate to look at a patient's underlying risk factor for developing high blood sugars. But we know that in steroid-induced hyperglycemia can occur acutely, and A1C is a measure of the past 3 months of your glucose values. So it wouldn't necessarily reflect acute hyperglycemia. In addition to this, an important point that I want to make is that anything that affects red blood cell turnover will affect the accuracy of your hemoglobin A1C. So any sort of factors that would increase or decrease red blood cell turnover will lead to misleading A1C results. So things that lead to lower red blood cell turnover, things like iron deficiency anemia, for example, could falsely elevate your A1C, and things that lead to higher blood turnover, things like hemolytic anemia, or patients who are on treatment for iron deficiency anemia could have falsely depressed A1C results. In addition to that, transfusions or patients who require multiple transfusions can have A1C values that are not reflective of their actual blood glucose levels. And in fact, transfusions have been shown to reduce A1C levels in patients who have hyperglycemia. So what are some other biomarkers we can look at? One of the big ones that's been talked about apart from the A1C is fructosamine. And fructosamine, instead of looking at glycated hemoglobin, looks at glycated proteins and glycated albumin. And the reason why this was looked at was because proteins have a lifespan of about 2 to 3 weeks. So this would be able to look at glycemic patterns over a much shorter time frame than your A1C value could. And so if we're looking at fructosamine, this could be less affected by anemia and red blood cell turnover. But again, we have to look at what exactly is fructosamine. So with fructosamine being a value of glycated proteins and glycated hemoglobin, we understand that anything that would affect your albumin level would also affect your fructosamine levels. So while this would be an option for those who have anemia and higher red blood cell turnover, it's not something that is accurate when your albumin is low. So fructosamine is not accurate with the serum albumin of less than 3, which is something that we commonly see in the ALL population, and would again make this not the ideal method for looking at glucose values and malglycemia in ALL. What about oral glucose tolerance testing? Because we've identified that malglycemia or hyperglycemia due to steroid use is seen postprandially. It's seen during the daytime. And this has been used in other populations to look at insulin resistance and abnormal glucoses. The way that OGTT is performed is that an appropriate amount of glucose is administered based off of body weight to our patients, and then glucoses are obtained 1 hour and 2 hours later, with a normal value being less than 140, pre-diabetes being 140 to 199, and diabetes being diagnosed at a value of greater than 200. So theoretically, you would think that this might be a better method of diagnosing malglycemia in this population, and it might be a one-time method for doing so. But there's still multiple limitations to this methodology. One is you need to be able to administer a glucose drink that is often not even tolerated in the adult population. And it may not be something that would be able to be completed for a lot of our patients. There's a time constraint with this. For a patient who's not admitted, they would have to sit for a good 3 hours in the lab to have these blood glucoses drawn. And then this is limited to certain age groups. So this isn't something that's commonly done below the age of 10. And so this can limit the utility of the OGTT, and it makes it a less feasible option for glucose tolerance testing. So apart from finger pokes, apart from A1C and fructosamine and OGTT, what is the last option that we can look at? And this option is something called a continuous glucose monitor, or a CGM. And it's something that's going to be a topic of further discussion later on during this talk. But continuous glucose monitors have risen and are widespread in their use in the pediatric diabetes population and are now really standard of care for their surveillance and monitoring of blood sugars. These glucose monitors sit in the interstitial part of in the subcutaneous part of your skin, and they read the interstitial fluid to look at glucose data every 5 minutes. So these devices are able to read your glucose every 5 minutes, transmit them to a device, and the device is able to display a blood sugar in real time. These devices are also able to tell us trends in blood sugar. So it's able to tell you if your blood sugar is stable, if it's starting to rise, if it's starting to fall. And you can even pull reports on the data to look at trends and what the blood sugar tends to do. So I've put in this report that looks at what are some of the information, what are some of the parameters that we can get out from these continuous glucose monitors. And in the diabetes world, we look at these reports every day. So we're able to look at how often our patients are in range. So time in range is one of those metrics that has been identified in the diabetes population. We're able to look at what our average glucose is. We're able to look at your day-to-day pattern of hyper and hypoglycemia. So there's a lot of information and a lot of potential benefits that can be seen with utilizing a continuous glucose monitor in this population. And it's something that does not require the use of finger pokes, does not require calibration with our most recent devices, and has been already implemented in a widespread fashion for diabetes. So potentially, we could have a lot of information we're getting from our glucose monitors. But when we're thinking about treatment again, what are some of the things that we can look at to identify the proper treatment of hyperglycemia if we're looking at steroid-induced hyperglycemia? And there's different literature that's been out there that's looked at, which type of glucocorticoid is administered and what would be the agent of choice in the adult population based off of the different pharmacokinetic profile of each of our individual glucocorticoids. So if we look at our short-acting glucocorticoids, this would be something like hydrocortisone. Hydrocortisone has a fast onset of action with a shorter duration. So hyperglycemia seen in this population tends to occur after 1 hour of its administration. You have a peak at around 3 hours after it's administered with a resolution 6 hours later. So this has a faster slope, a steeper peak, and a faster resolution. So in the adult world, what's been suggested for the initial treatment for steroid-induced hyperglycemia with our short-acting glucocorticoids is rapid-acting insulin in multiple doses. When we're looking at our intermediate-acting glucocorticoids, these are prednisolone and methylprednisolone. These tend to have a longer duration of action. So the hyperglycemia that you see with these agents occurs about 4 hours after administration, with a peak 8 hours later, and the peak tends to be less steep than the peak that you see with the hydrocortisone, and they tend to resolve about 16 hours later, but their duration lasts for approximately 36 hours. In adults, the agent of choice that have been suggested are long-acting insulin or NPH, but again, we don't have a lot of data on the pediatric population. And for our long-acting glucocorticoids, for example, our dexamethasone, these last longer, and the duration can last for up to 72 hours. Patients who are on dexamethasone can have hyperglycemia that starts about 8 hours after it's administered. The peak can be very variable, and it can last for 36 hours or more than that. And the agent of choice is long-acting insulin or glargine. What tends to happen with all of these agents is that the effects of hyperglycemia tend to increase over time. And so these patients often have increasing needs for insulin as they are on treatment for longer. We don't necessarily start with insulin when we have identified hyperglycemia in this population. The very first step, once you consult pediatric endocrinology, is non-pharmacological treatment. So we can do a lot of benefit by removing the use of dextrose fluids, removing dextrose carrier fluids in our medications. We can do a lot with dietary management, avoiding sugary beverages, looking at the amount and the type of carbohydrates that our patients are taking in. But this works for some people and, keeping their blood sugars in range. But for a lot of our patients, this is not enough to counteract the hyperglycemia that's seen. Our patients often have poor appetite, so limiting their diet may not be the optimal thing to make sure they're meeting their nutritional needs. And these patients are often also NPO for procedures and imaging. So that can limit the use specifically of only doing non-pharmacological treatment in this population. So what is pharmacological treatment for malglycemia? And the treatment of choice in this population is insulin. But when we're looking at which type of insulin and how often this should be dosed and what are the things that we can look at when choosing the right type of insulin, there's multiple different things we look at. And this is where, pediatric endocrinology is generally involved and gives advice. And there have been guidelines in the adult world that have looked at, glucocorticoid-based and weight-based algorithms, but these don't exist yet in the pediatric world. So when we're looking at standalone basal insulin therapy, this would be once daily basal insulin. This could be an appropriate initial thing that could be introduced for intermediate and long-acting steroids. As I mentioned earlier, hyperglycemia tends to increase as the day progresses and can last for over 24 hours. And while there's been studies in adults that have looked at the effectiveness of this therapy, we don't have similar studies in the pediatric world. A basal bolus regimen is often necessary for persistent hyperglycemia and is generally something that's seen while on intermediate or long-acting glucocorticoids. Again, we don't have dosing guidelines specific to pediatric ALL. We as endocrinologists fall back on our experience using insulin, but there isn't anything protocolized that we can draw back on. Prandial insulin is something, or mealtime insulin is something that is often suggested initially as treatment, but it doesn't account for that progressive increase in insulin resistance. So what generally happens for patients with significant hyperglycemia is that these patients will be started on prandial insulin and they eventually go on to a basal and bolus regimen. We don't have any studies to prove superiority of one regimen over the other. And so we have to fall back on our own knowledge and come up with what is the most appropriate treatment plan on the endocrinology side. But this is something that potentially could be looked into as time goes on and as we're able to get more information on our glycemic parameters. So we talked about how insulin is the most appropriate treatment for steroid-induced hyperglycemia in this population. But we know that insulin is given as an injection. It is not something that is easily started. Patients have to be taught how to give insulin. In addition to insulin, we have to teach patients how to watch for hypoglycemia, teach them how to use glucagon. And so what are our non-insulin options and why are they not an option for treatment in steroid-induced hyperglycemia? Because they have been explored in the adult world, at least, for the treatment of steroid-induced hyperglycemia. And one of the big agents that's talked about and one of the big agents that's well known for its use in the pediatric population is metformin. So is metformin an appropriate agent for steroid-induced hyperglycemia and ALL? And the answer to that is it's not an appropriate initial treatment. First off, because it has a slower onset of action, so it may take several weeks to fully get to its full effect. And so for acute hyperglycemia seen in this population, it wouldn't necessarily improve the blood sugars in the manner in which that they need. There's also concern about toxicity with metformin. So the different toxicities seen with metformin use are things like our gastrointestinal effects, things like diarrhea, nausea, abdominal pain. These patients are already at higher risk for these side effects because of their underlying chemotherapy regimens. So that can limit the use of metformin in this population. These patients already are on other hepatotoxic medications, which can increase the risk for hepatotoxicity that can be seen with metformin use and the increased risk for lactic acidosis. And these patients are also at higher risk for renal impairment as well. There have been very small studies or no studies that have looked at, the safety and efficacy of metformin for children with ALL. The study that I've looked at or referenced here in this slide looked at safety and efficacy of metformin for children with ALL with a very small sample size of 17 patients and was a retrospective study. But the studies that have been performed have not been nearly as well established, and they have not been strong enough to come up with good guidelines or good recommendations for the use of metformin and the safety of metformin in this population. Another agent that has been used in the pediatric population are your sulfonylureas, and these are usually dosed at meal times, and they can have acute effect and have been shown to reduce postprandial hyperglycemia in the adult world, and are actually a recommendation in other parts of the world for steroid-induced hyperglycemia in adults. But in the pediatric ALL world, in patients who have high risk for hypoglycemia, these confer even higher risk for hypoglycemia. And so again, these are not recommended for use. And we also don't have enough data in the literature to support their use for steroid-induced hyperglycemia. We can think about our SGLT2 inhibitors, and there's several approved in children above the age of 10. These are Jardiance, Farxiga, Evocana. And again, we have limited data on their efficacy and treatment of steroid-induced hyperglycemia, especially in the pediatric world. There's a lot of toxicities associated with SGLT2 inhibitors that are concerning, specifically in patients with ALL. These patients are at higher risk for genitourinary gangrene, fungal infections, candidiasis, in addition to increased risk for UTIs and acute kidney injury. And in a patient population that's already at high risk for infectious complications, these would, again, not be the appropriate treatment modality and is not something that would be initially recommended for treatment. And what about our GLP-1 agonists? So these are agents that have had a lot of over the past couple of years, especially against obesity, and they're widespread in their use in type 2 diabetes. And when you look at the mechanism of action of GLP-1s, you can often think that these would be an appropriate way of counteracting the insulin resistance seen after glucocorticoid therapy. Exenatide specifically has been used in the adult world and has been shown to have reduction in postprandial glucose values. However, these have not been studied in the pediatric world. And there's, again, side effects and toxicities associated with our GLP-1 agonists that would make it an inappropriate treatment of choice in the ALL population. So there's a lot of acute GI adverse effects that you can see. GLP-1s decrease your gut motility, and these patients have nausea. They can have a lot of vomiting. They can have feeding intolerance, and they can even have pancreatitis. And we know that pancreatitis can increase your risk for beta cell dysfunction and itself can cause hyperglycemia later on. So we know that insulin is a treatment of choice, but we don't have treatment protocols. Once insulin is suggested as a treatment option, that's usually when pediatric endocrinology is involved. We know that hyperglycemia can occur in certain time points in chemotherapy, but again, we don't have protocols that have looked at specific surveillance time points that we can look at. And we don't have a lot of pediatric data available at this point to come up with those treatment protocols. And this is something that is an increasing topic of interest as time has gone on. To date, we haven't had any studies in ALL that have evaluated glucose in a continuous manner. And so this is an interesting topic that I'd like to talk a little bit more about because we could potentially get a lot of information from our continuous glucose monitors that could help with the development of these protocols. But a continuous glucose monitor is often classified as a device, and the most important thing to look at, or an important first step to look at before we look at CGMs and specific glucose patterns in this population, is whether utilizing CGMs in this population is feasible and tolerable. Because we want to make sure that we're able to actually implement a larger study that would be able to utilize CGMs to evaluate glycemic patterns. We've already utilized CGMs in other populations and proven their safety and effectiveness. So in hematopoietic stem cell transplant patients, for example, CGM use appears to be both safe and feasible with minimal adverse events. And CGM monitoring has also been used in post-kidney transplant patients to look at glycemic abnormalities. To look at CGMs again, as I mentioned before, these devices sit in the subcutaneous tissue and they continuously read and transmit real-time glucose data every 5 minutes. These are water resistant, can stay in the body for up to 10 days, and they can transmit glucose values to a mobile device or a receiver. And there is a lot of data that can be obtained from these devices. For these devices, the glucose values are recorded every 5 minutes. They're recorded with timestamps, and you can actually download CSV files for each individual patient that shows all of the glucose values that are recorded every 5 minutes over the time period that these patients are wearing the device. So the amount of data generated by these CGMs is large, and the amount of information on glycemic patterns that we could potentially obtain from these monitors could be really instrumental in creating a lot of these surveillance and treatment protocols that we don't have yet in this population. So my fellowship and my scholarly work has looked at the feasibility and tolerability of continuous glucose monitor technology in pediatric patients with ALL. What I performed here was a small pilot project of 10 patients with the purpose of looking at barriers to its use and acceptance by patients, caregivers, and staff for this technology, with the purpose of designing a larger multi-center trial through the Children's Oncology Group to eventually look at glycemic patterns with the CGM. What was utilized in the pilot project was the Dexcom G6 Pro CGM, which is a research device specifically used in this population. The research mode means that patients and providers were blinded to the information obtained during the wear period. And so we were not aware of the glucose values in our individual patients, but we wanted to make sure that we were having our patients utilize standard of care for the pilot. Dexcom did provide our study with the required materials and technological support. We had specific inclusion criteria, so our patients had to have a diagnosis of lymphoblastic leukemia or lymphoma. They had to be between the ages of 2 to 25 with appropriate skin sites for placement of the CGM sensor. Our patients who were pregnant or did not have appropriate skin sites were excluded from our study. And to look at our study design, once an appropriate patient was identified, we approached our patients for consent. We looked at the reasons for why the consent was denied. But once we were able to obtain consent for our patients, we completed baseline information, things like height, weight, BMI, glucocorticoid dosage, whether they had anemia, recorded that information, placed the device, kept the device on for 10 days. Patients returned to their normally scheduled visits 1 week later. The device was removed. A new device was put in. CSV data was downloaded from each device, and that data was stored for us to look at after the study period was completed. We were able to identify 13 patients who met study eligibility, and of those, we were able to consent 10 successfully, giving us a consent rate of about 77%, which is very high. Of our patients who declined enrollment, the 3 patients who declined enrollment had different reasons for why they declined. The first patient felt overwhelmed with their new diagnosis of ALL. The second patient had had multiple previous treatment-related toxicities already and were afraid of further side effects with use of a CGM. And the third patient felt unable to complete the full wear period. And our patients wore these devices for a total of 4 weeks. Our patients were sent home with patient logs to document how they were able to tolerate or any sort of comments they had after wearing the CGMs. And when we looked at the patient logs that came back to us, the majority of these logs are blank. When we look at our adverse event monitoring, we really only had 1 patient who had any sort of adverse outcome. So there was 1 patient who had very mild discomfort and bleeding around the insertion site. We had 1 patient with some sensor adhesion issues, and that was the 1 patient who was unable to complete the full wear period. So overall, our patients were able to tolerate the CGM well and were able to keep it on with minimal adverse events. When we're thinking about feasibility of its use in our ALL population, we had a high consent rate. So we can surmise that our patients with ALL would be open to utilizing a CGM for glycemic monitoring. None of our patients withdrew from the study, demonstrating that we probably have low risk for adverse events from the use of a CGM, and it was well accepted by our nurses and study staff. So because these CGMs require placement and removal from our hem-onc nurses and study staff, we also wanted to make sure that it wasn't something that was going to increase in more time in their visits or more complications in their visits, and it was something that was very much accepted And actually was very something that was exciting, seemed to be as an exciting development by our hem-onc nurses and staff. From our data that we were able to generate from our 10 patients, we were able to take those individual CSV files and independently analyze them with our software to generate these ambulatory glucose profiles. As I mentioned, the amount of data that can be obtained from these CGMs is really large, and you can analyze this data in different ways. And there's even been independently generated algorithms for coming up with different ways of depicting this data. So what I've created for each of our individual patients that we were able to consent and incorporate into our study are these ambulatory glucose profiles that look at a 24-hour time period and looked at glycemic trends per hour period. The dark blue line confers the median glucose, with the less dark blue shaded area looking at the median 50% of glucose values, and the lighter blue area looking at the median 80% of glucose values. So there is a lot of information that can be generated, a lot of ways that you can look at this data to look at glycemic trends to give us knowledge about what we expect in this specific population. So the overall conclusion specifically from this pilot is that while assessing feasibility and tolerability is the first step for doing research on a larger scale, we have proven that CGM use is both feasible and tolerable for pediatric ALL patients. We had a high consent rate. Our patients were excited about the use of this technology, and there were minimal adverse events seen in this patient population. We also didn't have any differences in acceptability or consent rates based on age or sex. We recruited an equal number of males and females, and acceptability really remained equal among all groups. So we really feel that this is going to be an exciting development in the future when we're looking at evaluating glucose patterns in this population. This is a small pilot study of 10 patients. So of course, the limitation of the study is going to be our smaller sample size. But another limitation is the fact that we utilize the research mode of the device. So there are other barriers to using CGMs that weren't looked at within the study. Things like the hassle of alarms. So a falsely low blood sugar or a falsely elevated blood sugar can be a barrier to using CGM use. Pairing and connectivity issues has also been seen in other studies that have looked at CGMs, and it's not something that we were able to evaluate because we utilized the research mode. So when we're looking at what our pilot study has taught us, this was really the required first step to explore the use of CGMs for pediatric ALL patients so that we could potentially utilize them in a larger pediatric oncology trial to actually evaluate glucose trends during different phases of chemotherapy. Once we're able to have more information on these different trends, we'll be able to create different protocols for glycemic monitoring and insulin initiation for ALL patients on treatment. We'll also potentially be able to get more information about the risk for hypoglycemia following glucocorticoid withdrawal, because currently we're not looking at those glycemic patterns in a standardized way once those glucocorticoids are withdrawn. And there's implications for CGM use in other high-risk populations. Glucocorticoids are not unique to the ALL population. They're used widespread in transplant and chronic kidney disease and rheumatological diseases, and hyperglycemia is seen in those populations as well. So this could be an interesting device or interesting method for glycemic surveillance in these other high-risk populations as well. So for what I want you to take away from this talk is that specifically with ALL, these patients are at high risk for glycemic abnormalities. We have a lack of pediatric-specific data in this vulnerable population, and we don't have any evidence-based protocols for the management and treatment of hyperglycemia and hypoglycemia. CGM use can potentially provide this missing data so that we can develop these needed protocols long-term. And that's pretty much what I have for you all today. I want to acknowledge that this was a multidisciplinary research effort. So I want to thank Dr. Grimes and my research team on the hem-onc side with helping with the use of technology in this vulnerable population and with the help in getting this pilot study moving forward. This was a challenging IRB process. So I want to shout out also to our research staff in helping getting this through. Dexcom did provide us with supplies and technological support, and I did have help with from Dr. Keck for the independent analysis of our CGM data downloads. And so these are my references, and open to any questions or comments you all might have.
Thank you, Dr. Khan, for that wonderful presentation and understanding malglycemia in patients with ALL. Let's see if anybody has any questions or comments for you. So what is the cost? How expensive are these monitors, the continuous glucose monitors? And they have to be replaced frequently, is that right? Every 10 days, every 2 weeks? So
Yes, they do have to be replaced every 2 weeks. And that's a really good question. So if we are looking at each individual glucose monitor, it depends based off of which brand and which type. They can each be a couple $100s. So it can be an expensive device. Our patients who are on insulin in the diabetes world, these patients do have the devices covered by insurance. It's something that's covered under Medicaid. So it's not something that most of our patients pay for out of pocket. But you're right, the cost of these devices is higher than that of a regular glucometer that you can buy for maybe $20 at CVS.
there are also non-invasive glucometers. Now they're advertised everywhere, especially in Amazon. I've seen some advertisement. How comparable are those to the continuous glucose monitoring? You put them on fingers and you get oximeter as well as glucose monitoring.
So it's never going to be as accurate as something that's actually inserted within the skin, right? So the difference between that and a CGM would be a CGM is actually measuring the interstitial fluid of a patient. So in addition to that, it's a continuous method, right? So this is going to be able to give you 10 days of information versus just a small snapshot. So the amount of data that you can get and the accuracy is going to be higher from a specific CGM.
Thank you. Other questions, comments for Dr. Khan? So you said only one patient had minor bleedings because many of these patients have low platelet counts, and I was concerned about bleeding, but doesn't look like that's a major issue.
It's not, and remember, this is sitting just underneath the skin, so it doesn't seem to be a major issue. It was something that was a concern initially with introducing a device that's going to sit under the skin. But these patients are getting all sorts of other procedures too, lumbar punctures and other things that are more invasive. So the risk of a CGM is pretty minimal compared to those other things.
Other questions, comments? Doesn't look like. Thank you, Dr. Khan. This was our final presentation by the graduating fellows. So congratulations to all 5 fellows who did a wonderful job presenting their research. We'll meet you again next week for another presentation, not by fellow, but a faculty. And have a wonderful weekend, wonderful week. Thank you, Dr. Khan, again. I'm going to conclude this morning's Grand Round.